Hi, welcome to this second part of the lecture on the neonatal hearing screening, and now what we are looking at is where we stopped and we move from there. So, if you recall, right, we were talking about the gaps in neonatal hearing screening. The gold standard is ABR, which is auditory brain stem response, and in the gold standard we only look for first 10 milliseconds, right. But what I said in the last class is that if you go for mismatch negativity, then there can be an additional biomarker which will not only look till the auditory thalamus, but also till auditory cortex. That means that we will have a way of looking at the complete entire auditory pathway, right from outer ear all the way to the auditory cortex. And how can we do that? We can do that by looking at the further signals which are till 200 millisecond and so on. So, in those things we will look at P1, N1, P2, N2, right, P1, N1, P2, N2. So, if you see the slide, we were discussing that from the hearing it goes to the auditory thalamus, and if you further look into that it can reach to auditory cortex. So, can we add one more marker which we call mismatch negativity to not only look at ABR plus but also to look at the MMN. Okay. So, this is what it is, and we have also seen that in case of the ABR there are 7 peaks for normal subjects, and if the subject has a difficulty in hearing, right, then it would be different, and particularly peak number 5 is what is generally of interest in the case of the hearing. Now, if you look at the this particular image, we have AABR technology and OAE technology. So, OAE is autoacoustic emission, ABR is auditory brain response, right, brainstem response. So, now here you can see that it goes to the cochlea, it goes cochlea to the brainstem, and that is it, there we stop, right, there we stop. But if we can go one step further, then it will be helpful. So, we have seen that there is no system to check the entire auditory pathway. Mismatch negativity is attention free, is non-invasive, cost effective, and takes advantage of the current leak. I told that the skull is not completely fused, and that is why there is a current leak, because what we call in technical terms as a anterior frontally, and that is it's open, and that is why it is easier for us to look at the mismatch negativity, because there is a only cognitive event related potential that is present at time of birth. Okay. So, we need to look into that particular aspect as well. Mismatch negativity is only valid biomarker of the neuronal auditory processing at the time of birth, and now we have seen this particular thing, right, where we were able to see that how we can generate a different auditory stimuli so that to capture the ABR or to capture the mismatch negativity or AEP or P300. Now, here we are talking about only AEP and then MMN and then P300. So, P300 is positive peak at 300 milliseconds that arises for the unexpected event in a general ecosystem. So, here you can see that we apply the stimulation to the ear, and we acquire the signal, process the signals, and then we can understand how to reduce the number of epochs, number of cycles, so that it will be faster. So, that can be done with the help of the wavelet analysis. So, let me just play once again for all of you that how the auditory stimuli generation sounds like. Okay. This is AEP2, mismatch negativity. See, every fifth one. P300 randomly, right. So, this is how it is done, that we have AEP, MMN, P300, and the stimuli can be generated with the help of the Arduino. Okay. We can also use other ways to generate the stimuli. Now what we want to do is, if we have the similar band for a neonate, right, then we can, if we get the signal proper like EEG signal, we can say that it is conclusive hearing test passed, or inconclusive or conclusive refer to an audiologist, right. So, if the yellow and red light is there, that means that a neonatologist or sorry the audiologist has to intervene. For the green thing, no need to worry about it. So, can we make a band that can be placed at every primary health center? That is our idea. Now, here you see on the left hand side, which is on here where my mouse is there, the Matlab based ERP extraction technique is there, where you data acquisition and data and event acquisition occurs, where you followed it by the filters, band pass filter between 1 to 30 Hz and notch filter at 50 Hz, so that you can create a event creation and epoch generation, and then there is artifact rejection followed by the bin operation and plot generation. So, here we have successfully realized the event related potential, which is MMN and P300 script we have designed, and this is used to automate the signal processing for the batch files. Now, here let us see this video. Okay. So, what exactly you see in this video? These are the waves that are coming off, right. So, whenever she clinches, you see clinching, the signals are different, right. Whenever she is blinking, the signals would be different. Okay. I will just play it again, you see that whenever she is blinking and you say signals are different. Now, whenever she is clinching, it will be different, you see. Now, this is just to understand that what are the noise in these signals, right. We just do not want to understand only signals, but what are the noise in the signal, so that we can remove all this noise and focus only on the data. Now, you see this one, this is the baby friendly version of the device. Right. So, you have seen how this neonatal hearing band can be designed. We have also shown you the blown up diagram of the same band, and you can create this or you can fabricate this device, or you can develop this device using additive manufacturing, which is 3D printing technique. Of course, there are electronic modules that we have been discussing as a part of this course separately, and the signal that is acquired has to be the pre-processing signal has to be done. Pre-processing has to be done, post processing has to be done to remove the noise and only look at the signals. These are the NHS headband top view, front view and side view, the engineering drawings what we call. So, let us go to the next slide. Now, here what we see? Here we see that there is a prototype specification. Now, once you develop a system, you need to understand that you need to compare the system with the existing system. So, this is a Nav Pro 1, you can see a system, you can see here whether for the baby, there is another one MB11 Bera phone, right. Both of these are extremely costly technique, but at the same time technology readiness level of our system here is about TRL 5. Skinning method is Brainstem and Cortical. Brain wave acquisition is dry and gel free. Circumference of the headband 33 to 40 centimeter. We can change that the shape, and then you can go further. Head size adjustability is possible. Estimated weight of the band is 40 grams. Power requirements is 6 volts. time, how much time it takes, 15 minutes, and this is including subject preparation. Okay. So, in reality when we go for only ABR, it is really less than a minute. If it is MMN, right, it is a little bit time consuming, but we can reduce this further by using wavelet, as I told you earlier. Can you recharge the batteries? Yes. Auditory signal generation is programmable. Output display printing is yes. Portability yes. Modularity yes. Right. So, this is a way of looking at it. You can see that putting patches at different area of on the baby's face is not really advisable, because baby skins are very soft. Sometimes using the tape also affects the skin. Okay. So, we need to be very careful about how to use the system. Now, these are comparison about what kind of parameters can look at. Brainstem response our system can do, cortical response yes, headband system is yes, portability yes, very high, cost is extremely low compared to the existing cost of this commercial products, and ease of usage is extremely high and very easy to use it. So, the translation potential, if you look at the translation side of this particular work, then a quick non-invasive and objective multimodal approach to evaluate neonatal auditory pathways and index auditory cognition. There is a deployment in PHCs, which is primary health centers, and CHCs across the country, and aiding the current gold standard. Right, we are not removing anything, you do understand this thing. None of the technology that I teach you has to do anything with removing or replacing a clinician. We should not be replacing the clinician, we should aid them, right, we should help them, we should empower the semi skilled personnel like ASHA workers, right, so that they can use this technology, and where clinicians cannot be reached, where the technology which is existing technology of costly technology 14 lakh 15 lakh cannot be commissioned, cannot be placed, then in that cases we can use our technology which is much more affordable, can be easily used, can be used for screening neonates which are right now not screened at all. So, the technology that we are generally focused on is to aid, to help, to empower. Alright, always remember that the technology should not be developed to replace. The replacement is difficult job, right. We should empower. Finally, the third one is exciting possibility of auditory threshold identification and neonatal epilepsy screening system development by increasing number of electrodes. If we increase number of electrodes, again if we are similar to 10-20 system, we can not only look at the epilepsy in the young adults, but also in the neonate as well, and that is the advantage of this particular system. A high density EEG equation system can specially localize the brain abnormalities like tumor. Right, we require approvals like CDSCO, right, we intend to apply ISO 13485 C certification and lot more. So, anyways, so if you see the signals, right, you can very easily see the mismatch negativity. Generally it is between 200 and 300 milliseconds, and every time you can see there is a peak coming up here. Even the grand average also you can see a peak at this particular point. It is a negative up, as you can see here. These are the 7 peaks that generally we are supposed to observe in the adults, and peak 5 is of more interest. Peak 5 here, and then peak 5 here. Okay. We are working on improving the filtering by using some custom filter script, and also automation is in progress. So, these are some of the things how we get it done. Now, like I said, that ethical committee clearance is very important. Without having this clearance, you should never, right, use any human subject or even the samples from the human subject, right. Without ethical clearance and without the consent, it is prohibited, it is not allowed, it is against the ethics. So, it is always good to get the ethical clearance before you start working on it. We have a collaborator from Indira Gandhi Institute of Childhood, and we have collaborator from KIMS Hubli, Dr. Manjunath Dandi. From Indira Gandhi we have Dr. Pratik as our collaborator, and also Pratik Senior, he is also there for us to utilize this system, or to put this system on neonatal neonates head and to screen those neonates. Okay. So, these are two clearances as you can see here, and that is the end of this particular module. So, what we will do is in the next module we will look into something called implantable MEA for recording neuropotentials. Okay. So, now we move one step further. Until now what we are looking at? We are looking at how the what is EEG, how EEG generated, okay, how EEG can be used. If we understand EEG signal, then if there is a normal subject versus epileptic subject, then how the EEG signals would vary, fine. Then types of epilepsy, generalized, absence, focal, focal to generalized, good. Next step, if you want to use this as a system, then can you use it for hearing screening? So, yes. How can you develop a band? This is how we develop a band, and how we give the stimulus. These are the different stimulus that we can look at today. Good. Now, we will go one step further and we talk about when the epilepsy is intractable epilepsy. That means that even by taking the drugs, the person is not free of epilepsy. In those cases we need to the way to do is by implanting a electrode and then waiting for the episode to occur, and exactly where the episode occurs, then the tissue is resected, and also it is one way of looking at it. The another side of it is that if there is a new drug that if there a pharmacy comes up with, right, how can we test the efficacy of the drug? That means that the testing the efficacy of drug is very important, since some drug may be more effective compared to others. So, this is generally done in vitro model, which is inside the laboratory, then followed by the ex vivo model, which is a tissue taken out from the animal or blood or other samples and then tested in the lab, and then goes to in vivo model. In vivo can be animal models, right, can be smaller models like rodents, it can be a rabbit, it can be a pig, or it can be a monkey, non-human primates, before we go to the human, which requires a lot of clinical trials and then move further. Now, my point is that if you if the drug that is developed or formulated by a pharmacy pharmaceutical industry, then can we understand the effect of that drug, right, how that drug would be effective. If it is effective, it will treat epilepsy, but it is not effective, then no point, right. So, with that purpose in mind, right, we again focus on epilepsy, but in this case what are we are talking about? Micro electro array that can be implanted in a brain, and that from the implant we will know how the whether when there is epilepsy occurring, and if the episode is there or not, or if you give the drug, whether you can recover the baseline. So, let us understand from the slide. If you see the slide, we can see that approximately 50 million people worldwide are epileptic, and making epilepsy one of the most common neurological disorder, and you see close to 10 million people are suffering from epilepsy just in our country. Now, this is a low number because this number would be way more. This data is from 2016, right, and 2014, right. The epilepsy effect is from 2022, but the data about the Indian epilepsy in India is a little bit older. So, my point is that this epilepsy increases for several reasons. One of the few reasons for you to understand, right, because you are the future, and is that sleep well. Okay. If you sleep well and if the stress level is less, then less chances of having this kind of depression, seizures and epileptic episodes. If you do not sleep for 5 days, 6 days, 7 days, 8 days, 9 days, suddenly you will see that everything will come up, alright. So, as important as for you is to keep your heart strong, equally important is to keep your mind strong, and to keep your mind strong you need to sleep. The best medicine is to sleep. Okay. 8 hours is what is recommended. If you can find 8 hours in your life and sleep well, then less number of all the other kind of mind related or mental disorders would be there. Okay. Let me again tell you, since we are taking the advantage of our understanding towards some advanced neuroscience, we particularly, that includes me also, okay, are brought up in a society where we think that going to a psychiatrist is a bad thing, you are mad, you are mental. It is not that, guys. Okay? It is absolutely not that. If I go, let us say if I break my hand, I go to a doctor, oh he broke his hand, it is okay, right. If I have some health related problems where I cannot breathe well, I cannot walk well, I have to go to doctor, oh okay, that is fine. But if I cannot sleep well, if I do not feel well, right, I go to whom? Who is the doctor? A psychiatrist, is not it? Psychiatrist is a doctor. So, I go to that person and he gives me a treatment. Then going to a psychiatrist is bad, but going for all the physical health related activities and complaints to a doctor is fine. That is how we have accepted it. It is wrong practice. Since we are looking into the important applications in neural engineering, do understand that your mind is as important as your heart, and going to a doctor if you do not feel well, which is a psychiatrist, is absolutely 100% okay, right. Talking to someone, understanding it, improving the sleep. If somebody helps by talking to you and gives you a medicine which will improve your sleep, right, which will give you a mental peace, which will make you feel better, right, which will relieve your stress, right, why not to go? So, that is my request to all of you, that change that mindset, change the mindset, start telling people going for a mental health checkup is as important as going for a physical health checkup. That is, our body is no separate than mind. Okay. So, do understand that when you say that why number of cases are increasing, why epileptic episodes are increasing, because people are stressed, people do not sleep like they used to sleep. So, sleeping is one of the most important jobs, right, at your stage particularly. Do not leave that 8-hour cycle, okay. Try to catch that, sleep well, be healthy. Now, coming to that number of cases in epilepsy, 50 million worldwide, 10 million in India, and then in epilepsy we already know seizure is a neurological disorder due to abnormal, excessive and hypersynchronic discharges, like from an aggregate of neural or central nervous systems or neurons, and epilepsy describes clinical phenomenon of a condition of recurrent and chronic seizures. Now, this is very difficult because person cannot control. Sometimes if the person is driving and having the episode, there can be accident. While walking, the person can fall, while climbing stairs the person can fall. So, epilepsy has detrimental effect. 6 classes of anti-epileptic drugs are available. You can see the screen now, where you can see that there is a sodium valproate, there is a phenotine sodium, and so on and so forth. So, these are for the treating the epilepsy, okay, for treatment. However, these drugs are not epileptic specific. Okay. Moreover, medication is not available for refractory or I said intractable epilepsy. Here the medicine will not work, and the only thing will work is to resect the tissue from the brain. The EEG, right, or electroencephalogram records with the scalp electrodes. We have seen 1020 system that are used to screen subjects for epilepsy and approximate the epileptic focus. However, seizure activity occurring with the deeper brain structures might overlooked by scalp electrode EEG. Okay. So, intractable electrodes, intracranial electrodes are used to detect and localize seizures in deep brain regions. So, these are different BCI approaches, right. What you see on the left side, which is here, is non-invasive when you go for EEG, right, then MEG, but invasive when you go for electrocardiography or stereo EEG, that is by implanting the electrodes inside the brain, and then intracortical implant. You put that implant inside the brain forever. Different approaches. So, now what happens is that in this kind of activity, so you can have either non-invasive or invasive methods. This again the same thing, right, 1020 system, the way the electrodes are placed on the head. Now, I said that there is something called intractable epilepsy. You can see here in this case there is a craniotomy. That means that removing the part of the skull, and when you remove the part of the skull you will reach dura. When you open the dura you will see the brain. Brain is floating in a cerebrospinal fluid, okay, and it is a pulsating effect, is brain pulsates. Now, if I had to place this microelectrode array on the brain and suture the entire thing back, then I can get signals from each electrodes, okay, like each electrodes I will get signals from. So, you can cover the motor area, you can cover the sensory area, and these are the grids. So, these are about 20 electrodes in this particular MEA, okay, microelectrode array. This is the example of the SEEG stereo EEG illustration. So, electrodes are placed inside the brain, okay, electrodes are placed inside the brain, alright. So, this much we understood about how to implant the electrodes, whether it is inside the brain or is non-invasive, then it is either MEG or it is a EEG approaches. So, why invasive BCI, right, why invasive technologies. So, you can go from EEG to IEEG to SEEG. So, one is that the biopotential amplitude increases, the frequency increases, signal to noise ratio increase, field of view is less, area of contact is smaller, spatial resolution is better, invasivity and complexity is higher, influence of anesthesia is higher, influence of narcotic and analgesic is higher, and tissue damage is higher. These are the different things as you go from EEG all the way to the SEEG. So, the application, but the application perspective is that it can be used for brain functionality mapping, very important. Extraoperative, because epilepsy surgery evaluation can be done. Intraoperative can be used to check the sensory outcomes during the surgery. Intraoperative, again it can be used with DCES, which is direct cortical electrical stimulation. Finally, brain tissue properties you can study with the help of IEEG and SEEG. The limitations are limited recording time, limited area of consideration, risk of damaging the tissues, there is a leakage which is cerebrospinal fluid leakage, intracranial bleeding, and there can be possibility of infection. So, there are several limitations associated with the invasive technique as well. Okay. So, let us now talk in this, let us take in the next class about how to design this flexible microelectrode array for recording ECOG signals. ECOG, as I told you, is a electrocardiography, it is signals that is taken from the brain. Okay. So, we will see that how can we design this implantable electrodes in the next class and then we will see that how we can, what are the fabrication technologies of fabricating this device, what are the casing that we can use, how the electrodes are how to be characterized before it can be used in the surgery, how the surgery can be done, some videos are there, okay, and followed by how the signals are acquired, and in the case of anti-epileptic drugs how the efficacy of these AEDs are measured. So, we will do that all that in the next class. If you have any questions, like I said, you always are free to ask me in the NPTEL forum, right. So, I will see you in the next class. Till then, you take care. Bye.